Good evening, everyone. Thank you for joining us tonight. My name is Donna, and I'm with Genesis Fertility. Conducting this evening's seminar is Dr. Jacob Kurgan. Dr. Kurgan is the Director of Male Reproductive Health with Genesis and will be speaking about what you need to know about male infertility. I'm going to ask everyone to please hold all questions until the end of the presentation. Without further delay, I will turn the controls over to Dr. Kurgan.
All right. Thank you, Donna. Thanks for the introduction. Welcome, everybody. I am Jacob Kurgan, Dr. Kurgan, and male fertility issues, it's a big topic, but we wanted to kind of distill it down to what you need to know. If you're thinking about it and what's out there, it's a big topic, but let's try to take like a bite out of it. And the good thing is that if there's going to be any questions, we'll be able to answer them towards the end. So hold the questions until the end, write them down, and I'll be happy to do my best to answer them. All right, so here we go. Right. So about me, if you are really interested, it's not that interesting, but if you're really interested about reading about me, just head on over to the genesisfertility.com website, find me there. This is me, my face, all right? You can read about me, but in a word, I'm the doctor you'll see if there's any question about male fertility issues. It's going to be me. I'll be talking to you, examining you. There's nobody else. I'm happy to do so, and you're welcome to read about the things I've done. So this is the agenda for today. We're going to have a little bit of introduction about the topic. We'll talk about some potential causes for male fertility. We'll also go over the evaluation. I think a lot of men out there have some fears about what an evaluation entails. It's really not that scary. We'll go over that. And also we'll talk importantly about treatment options for people that do have infertility. And we'll end with a conclusion, and we'll have some time for questions and answers, Q&A. You do not have to take notes, big X on that. These slides will be made available to anybody who wants. All right, introduction. So male infertility affects about 7% of men, which if you think about it, is actually fairly common. In America alone, that translates to at least a couple of million men. In Brooklyn, we have 2-3 million people, so you can do the math from there. I am busy, and we have a lot of experience at Genesis with this. And if you're suffering from this, or you think you might be, don't worry, you're not alone. Traditionally, when we would think about fertility issues of a couple, the woman would get evaluated pretty extensively, and a lot of times the male aspect was overlooked, and there has been some change of the tide with that, with us being a little bit better as a community in making sure that the men get evaluated as well. And that's really a great thing, because if everything's okay, great, at least we know. And if it's not okay, at least we know earlier. And the good news, most male fertility issues are treatable. Not every single time, but the majority of the time it is. All right. Let's go over a couple of definitions. The most accepted definition for infertility is the inability to conceive after a year of unprotected intercourse, so 12 months. If a female partner is older, usually around 35 or more, we say after 6 months, infertility is there. But that being said, we never turn anybody down who has any concerns. We have single men out there that are curious, they want to know. We have men who've just started trying to conceive or thinking about it. All are welcome. We also subdivide infertility into primary and secondary, just meaning you have been involved in a prior conception or you have not. All right. So again, infertility is a common issue. We have this 1 in 8 slogan that goes around. And you see, you got 8 couples, and on average, about 1 of them will have some fertility issues. So if it's not you or your neighbors, it might be your friend or relatives. It's very common. The more you ask around, the more you realize. How often is the male involved in the infertility issue? So we don't always know, but our best estimates are kind of broken down in this pie chart. So about half the time, 50% of the time, the male factor, the male side of things, is at least someone involved. In general, we think that about half the time it's a female factor only, about 20% of the time it's a male factor only, and about 30% of the time it's some combination. So taken together, about 50% of the time there's some male component. So this is an important thing that really should not be ignored. All right. Some causes of male fertility issues. There's a lot of them, and we'll get to the evaluation later, and you'll see we ask a million questions. And the reason is that almost anything that can affect a man in general can affect their fertility. Some of the things that can do this are hormonal issues. A lot of people have already heard about testosterone. Maybe they've heard about pituitary hormones and other things, and they're all affected, and they can both be a sign that there's a fertility issue, and sometimes they themselves, a hormonal issue, can lead to infertility. And if we treat that, it can improve. So it can get complicated. I'll show you in a different slide. But hormonal causes are a common thing that we see and something we definitely investigate. There's also genetic causes. About 7% of the time, again, not a rare event, there's some sort of genetic issue identified that we think is causing the fertility issue. The most common thing is something called Klinefelter syndrome. It's a very common condition. We have dozens of men who have Klinefelters, and most of them have fertility issues, sometimes severe fertility issues. It is, like I mentioned before, mostly treatable. And this is discovered with a genetic test. And most people that have it don't really know. It's a blood test that tells you. Neurologic issues, we have men, young and old, that have had spinal cord injuries or Parkinson's or multiple sclerosis, other things. A lot of these things can affect the ability of sperm to get to the outside world, and we can treat that as well. Environmental, this is a big topic. It's been getting traction in the last few years, where we're realizing that we've got men today compared to, let's say, a few decades ago, are in general more sedentary, poor exercise, regimen, not eating as healthily with processed foods, things like that. And we're realizing that maybe some decline in the sperm parameters in America and across the world might be related to that. Anatomic causes, this can refer to something like a varicocele, which, again, we'll go over it in the future, but its veins are a little bit big that can affect fertility issues. Some men choose to have a vasectomy, and then they say, oops, maybe I don't want to do that anymore. I found a person I want to have a baby with, and that's an anatomic issue that we can also help out with. And about a third of the time, despite our best efforts with a million questions and an exam and doing blood work, we don't actually know what's going on. But even in those cases, there's things we can do. All right, so for those of you that remember your biology class in high school or something, we've got these two important organs that are sort of the puppet masters of all the hormones in your body, the hypothalamus and the anterior pituitary. They sit kind of in the middle of your brain, and they tell in a man the testicles what to do, and in a woman their ovaries, and many other organs. But for our sake, the so-called HPG axis, hypothalamus, pituitary is the P, and G is the gonads. So they talk to each other, and we can actually measure a lot of these hormones, and they tell us what's going on in a man's body hormonally, and we can manipulate this for our benefit a lot of the times. So this is just a refresher. I just want to show somebody, showing you a scary slide, and it's scary on purpose. This is something I actually show my residents and teach my residents, because things can get a little bit more complicated, right? This is not too terrible. We could kind of understand that. This gets complicated. You have the hypothalamus, and the pituitary talks to the different cells within the testicle, and how the different hormones talk to each other, and things that people take or do that can affect all these hormones. So it's very complicated, but the good thing is I understand it. I think I understand it. Yeah, it took me a while, but I understand it now completely. And another good thing is, don't worry. There's no quiz. If you are a resident of mine and you're happening to listen to this, then yes, there is a quiz actually. All right. So let's talk about semen analysis. If you go to a doctor and you say, "Hey, how's my fertility potential?" If you're a man, almost definitely we'll ask for a semen analysis. This is probably one of our best tests. It's not a perfect test, but it's a very, very important test where you're given a cup. Here's a nice example of a cup. It might have a different colored top, but the cup is the idea. You go to a room and we ask you to so-called produce. In other words, give an ejaculate. Can't really have anybody help you. Can't have lubrication. We ask you for a certain amount of abstinence days of 2 or 3 or so. But once you give that sample, we're able to tell really a lot. The main things we look at are concentration, motility, morphology. So we look how many sperm you're making, should be in the millions. How many of those are moving, and are they moving sort of in a forward linear fashion as they should? We look at their shape. Do they have a normal head, a long tail, two tails, two heads? Different abnormalities can occur. And there's other things within the semen analysis that we look at, which again gives us a lot of information. And if you do a little formula of figuring out the TMC or the TMSC, the total motile count, that tells us, well, in the ejaculate, there was an X amount of millions of sperm. And that gives us a good predictive value to know, is there a chance to conceive naturally? Is there a chance to conceive with IVF, or do we need some other things to be done? Again, there's no quiz, but I did want to go over some of the so-called normal results of semen parameters. And the reason I put normal on purpose in quotes, so this is not normal in sort of a black and white fashion. I like to use the example: you go to your doctor and you say, "Hey doc, do I have diabetes?" The answer is actually fairly black and white. You can do a blood draw, hemoglobin A1C. If it's 6.5 or above, you have diabetes. If it's below, you don't have it. So semen analysis is a little different. The so-called normal results are not really normal. They're actually based off men who have fathered children, and these numbers represent the lowest 5% of men. So it doesn't mean you have a lower parameter in one of these, you can't father children, or even the opposite. You might have all these things normal. Doesn't necessarily mean that you can, father children. Plus, we throw into the mix the fact that there's another partner involved, and things get a little bit more difficult to interpret. So, not a small amount of time, I get consults where people say, "Hey, I think there's an abnormality in the semen analysis," and taken together, I say, I actually disagree. I think it's actually fairly normal, all things considered. So it's just worth noting that normal is a little bit more difficult to define. Another thing that I hear a lot of men and women and other people, even other physicians, talk about, they use the word semen and sperm interchangeably. Just a little anatomy lesson. Semen refers to the fluid that comes out when there's an ejaculation, where there's an orgasm, but the sperm is actually those little microscopic, cells that are responsible for fertilizing the eggs in the female. Semen is, the vast majority of it is not sperm. We got seminal vesicles, which actually I think this is mislabeled, but anyway, seminal vesicles make about 75% of the volume. The prostate, which you've probably heard of, again, that's mislabeled, it's actually here, is about 20% of the volume. And really, the sperm itself accounts for a very small amount volume-wise. So why is that important? The point is that you can't tell, looking with the naked eye, whether there is a normal amount of sperm, zero sperm, a superhuman amount of sperm. You can't tell. You really need a microscopic analysis of this, and that's where a specialized lab, such as the one we have at Genesis, really comes in and tells us what you have. Something also of interest, people don't know what a normal volume is, but anything above 1.5 milliliter, which is really a fairly small amount, is considered normal. And all those organs that I was showing you here The reason so many things are involved, they act as a vehicle for sperm to get where they're supposed to. And interestingly for me, semen is alkaline, not acidic, whereas the vaginal environment is acidic. So a lot of semen is there to sort of counteract that. So that's why it's not just sperm coming out. We need all this other stuff. All right. There is a subset of men when they're getting their evaluation, they're found to have azoospermia. So in other words, they might have ejaculate coming out and it looks normal to them, but when we microscopically analyze it, there's zero sperm there. This happens about 1% of the population, and men that we evaluate, about 1 in 7 or 15% or so turn out to have azoospermia. These two pictures below, these refer to the two reasons why you can have azoospermia. More commonly, it's what's called non-obstructive, which is kind of a bad name, but another way of thinking about it is you're not making any. So here, this picture over here, testicles are supposed to make sperm. They're not making any. So the reason there's zero coming out, it's not being made. There's no obstruction. There's nothing blocking. Less commonly, but we also see this quite a bit, is something called obstructive azoospermia. And in this case, the testicle is making what it's supposed to, but at some point there's a blockage, whether it's from an infection, from an injury, from a surgery, something that you were born with. There's different reasons, but you're making the sperm, they're just not coming out. So this is something that we have to parse out. By we, I mean I do, but we're able to do that. And the treatment differs depending on what we think is going on. All right, so how do we figure some of these things out? Let's talk about the evaluation. So the first question when we're evaluating for male factor is there a male issue? And I put 2 cups here because usually we ask to have, not always, but usually we ask to have 2 semen analyses done, especially if there's not stone cold normal results. Again, the way we ask for it to be done is about 2 or 3 days of abstinence, maybe up to 5, but not more than that. And then ideally twice, maybe a month apart. And depending on the results, we may need additional testing. Sometimes we need sort of a third one as a tiebreaker if there's really disparate results. We also have, in the last few years, realized that maybe semen analysis don't check for absolutely everything, and there's like oxidative stress and other things that might be going on. So there are these adjunct tests, such as DNA fragmentation testing. Also, some men make things normally, but it gets mixed in with the urine, and we can, again, test for that with something called a post-ejaculatory urine test. None of these tests are painful, and again, they provide a lot of information. So, to address potential fears of what it is that we do when we first meet as in an evaluation for somebody, really the most important thing I do is talk. And, we got Charlie Brown's teacher going, wah, wah, wah. So really the first, time we meet, 90% of it is talking. It's asking a lot of questions. We get nosy. We want to know everything because, again, almost anything that it can affect the overall health can affect fertility. So we ask about the partner, we ask about sexual history, past medical or surgical history, any cancer treatments, infections, childhood illnesses. These can all affect the fertility and give us information about what's going on. Another important part of the initial evaluation, usually only the first time we meet, is a physical exam. I've heard a lot of men have a lot of anxiety about this, the so-called gloved finger fear. The truth is that the majority of the time we don't need to do, a finger exam. We're not checking your prostate unless there's another compelling reason to do it. But the physical exam is very important. It's not painful, and we get a lot of information from the physical exam. And together with the initial history, we have usually a pretty good picture of what's going on after that first visit. Other things we do, blood work is very important. Again, testing those hormones can give us clues as to what's going on, can give us clues as to medications that might be helpful for the situation. So, we very often test the testosterone, certain pituitary hormones, And sometimes we look at other things like thyroid and diabetes testing. And men who are trying to father children, a lot of times we ask them for this male fertility panel just to make sure there's no infectious diseases that can be passed on. In certain men, if the semen analysis warrants it, we check for genetic issues. This, genetics are something you're born with, we really can't change, but finding a diagnosis, figuring out why things are happening is often very helpful. And sometimes we get information about a diagnosis, and that can give us some predictive ability, saying, all right, well, with this situation, we know that 40% of the time something happens, and we can counsel appropriately. Another important thing is because genetic material is passed on, and there's certain things that affect males versus females, we have some ability to predict what the chances that things are passed on. Once in a while, depending on the situation, we ask for certain imaging to be done. The most common things we do is an ultrasound. That's just a little jelly on the body, and here's the black and white pictures that come out of it. These are normal testicles on the left side here. MRI is another common thing. Well, not common, but something we do once in a while. Sometimes we look at the pituitary if we think there's an issue. This is not in every patient, but we do this sometimes. And the good thing about both these studies actually is neither of them have radiation, which I know concerns a lot of people. All right, so let's say we evaluated somebody, we had a good talk, maybe some a physical exam, some blood work, and now we're faced with still the problem of fertility issues. So we have to do some treatment. So what can be done? So I like to split it into kind of two categories: what you as the patient can do, and what we as the doctor can do. And one of the most important things that a man who's concerned can do is get evaluated. And I think if you're listening to this, you're probably halfway there at least. There's a lot of mental barriers sometimes to getting evaluated, but that's a very important thing. We'll also talk about healthy, not health lifestyle. And these are things you've probably heard before, eating right, exercising, avoiding certain things. We'll review that, but healthy lifestyle goes a long way. It may not be the only reason there's a fertility issue, but a lot of times it can contribute. What can we do? The doctors that see you, we can try to figure out what's going on and counsel appropriately. Medications, we prescribe medications all the time that can help, and in some men, procedures that can help us either fix the problem or at least get sperm to allow the partner to get pregnant. All right, healthy lifestyle. I'm sure everyone has heard this. It's sort of ubiquitous everywhere, but it's true. These things that everybody tells you, that diet, exercise, sleeping right, not being stressed, all those things are good for you, period. They're good for you from a cardiovascular, heart health, psychological health, hormonal health. And we are also finding more and more that male fertility is often affected quite a bit by how healthy your lifestyle is. So here we got I guess he's, this guy here is lifting some dumbbells. He looks like he's in pain. And a lot of people ask me, well, what kind of foods should I eat, doc? And it's a difficult question to answer. I don't think there's any foods that are completely off the table, and I think the key is moderation. The most commonly studied diet we have is so-called the Mediterranean diet, which is heavy on fruits and vegetables, not very heavy on proteins. And if you're going to be eating proteins, usually fish and poultry is recommended. It doesn't mean you can't have a steak once in a while. It doesn't mean you can't have a piece of candy once in a while, but generally avoiding a lot of red meat, avoiding processed foods and a lot of sweets is probably good for you. Again, not just for fertility, but overall health. And just as important, a lot of fun things are best avoided. Tobacco. be hard pressed to find a doctor who doesn't think smoking or using tobacco in any way is bad for you. And I agree. I think tobacco causes cancer, causes heart disease and other issues. And also we know that in men who smoke, there's a potential for sperm damage, especially oxidative stress in men who are smokers. Drinking, the vast majority of the world does drink some alcohol, and probably in moderation. 1 or 2 drinks here and there is not a big deal. Maybe there's even some potential health benefits of drinking wine, especially red wine. But excessive, people who drink and have a headache, like this poor gentleman right here, that's not good for you. So again, moderation is key. Another thing that we know, men's gonads, the testicles are outside the body, because temperature regulation is very important for proper sperm production. So testicles are outside, and if we're doing things that cause excessive heat, whether that's wearing underwear that's too tight and doesn't allow them to cool off, or people that go to saunas a lot, or people that work in a hot kitchen all the time, all those things we think can affect fertility in a bad way. So we counsel men about this and recommend avoiding those things. Drugs are a kind of a big thing that we ask about. There's a lot of legal and illegal drugs that can affect things. One of the most common things that a lot of people don't realize is testosterone, which is also kind of called colloquially steroids or anabolic steroids. They are actually pretty effective as a contraceptive. So I can take a perfectly fertile young gentleman, and if you give him enough testosterone, we can make him have 0 sperm. The way the hormonal axis in your body works, eventually steroids will turn off your body's production, and you will be kind of infertile because of that. So, that's a common thing I see, especially young men, and it's reversible with the right approach. Sometimes people have certain conditions that require prescription medications, and maybe those medications are very good at helping with whatever disease process is going on, but some of them have this side effect of causing fertility issues. So a lot of times we identify that, we can think of alternatives, we talk to the doctor who prescribes it to see if there's anything else we could be doing, and those things are reversible. So a lot of things can affect potential fertility. And I think this slide is about an important point. I like to tell patients I'm not treating a piece of paper with your semen analysis parameters. That's important. I want those numbers to be as good as possible. But, we're treating a couple trying to get pregnant most of the time. So it's very important to ask some questions. And we ask some basic questions about the man's partner. Importantly, how old is she? Does she have any medical issues? Has she seen a specialist? Does she have kids? Does she have a regular menstrual cycle? Things like that. And as you can imagine, the discussion is different. If you've got a man who has a 25-year-old partner, it's a little bit of a different conversation than if his partner is 45 years old. We do know that fertility potential falls with age with women, somewhat with men as well, but especially with women. So if we have mild abnormalities in the semen analysis and the partner is a little bit older, we might not be trying to make those perfect, and we might realize, hey, we need some assistance. So luckily at Genesis, we have some excellent physicians, and we have an excellent lab, and all the things we need for a proper female evaluation. And if intrauterine insemination is needed, IUI, or IVF, in vitro fertilization is needed, and that's kind of pictured here, something called ICSI. If that's needed, we have all that. So that's an important thing. And I see other urologists saying, hey, it's a mystery why there's infertility, but they haven't asked anything about the female. All right. So medications, prescribe medications all the time. A lot of times we're targeting any hormone issues that might be present. We might be trying to sort of boost the production of sperm. Sometimes we identify infections and we can give antibiotics. And sometimes men have no sperm issues per se, but the little blue pill, because of some sexual issues, can do wonders for some and really can help sort of with the delivery of the end product to get pregnant. We also do procedures. Fertility specialists like myself, we're surgeons. We do surgery all the time. Depends on the situation. One of the more common things we do and we see is something called a varicocele. These are basically, as this picture here shows, swollen veins. Everybody has veins draining the testicle. That's normal, but some men have it sort of wider, the diameter is bigger, and we can see that on a physical exam. We think that interferes with the way sperm are being produced, and a small procedure to fix it, or sometimes something called an embolization, which is done by another physician. But fixing those veins has about a 70% chance long-term of improving your semen analysis. So that's a common thing we see. Some men have an anatomic issue, like I said. They chose to have a vasectomy, which was a good choice at the time. And now they're thinking, hey, I want to reverse that. So the word vasectomy comes from the vas deferens, which is sort of the final tube that transports sperm from the testicles to the outside world. So if you've had that done and you want to reverse it, we do that surgery. Sometimes we can actually just extract sperm and use it for IVF. There's other blockages that we address. All that depends on the evaluation. There's a subset of men that, like I mentioned before, they make very good sperm. There's just an issue, whether it's neurologic or psychologic or another issue of getting the sperm out. Again, that's treatable. We have something called penile vibratory stimulation, which is done without anesthesia, has a 2/3 success rate. Some men have more severe issues and require something called an electroejaculation under general anesthesia with very good success rates. And again, we do all that as needed. In fact, I think there's either one other or no other place in New York City that has this device that's needed. All right. And, some men who have azoospermia, they have zero sperm, they truly don't have any sperm in the ejaculate, but maybe somewhere within the testicle, there are small pockets where sperm are being produced. So I like to say, if it's there, we can probably find it. What does that mean? We can do certain procedures, whether it's done with a little local anesthetic, just right here in the office, or sometimes under general anesthesia in the operating room. We can sometimes find sperm within the testicle that otherwise would never have come out. And this picture here, this is actually super magnified under a surgical microscope. These tubules are all sort of devoid of sperm, but the circled area looks a little plumper. That might have sperm, much more likely to have sperm. And if we do find it, our lab identifies it, freezes it, and then that could be used in the future with in vitro fertilization to get a pregnancy. The type of procedure we do, whether, like I said, it's bedside or in the operating room, and what area of the anatomy we target, that all depends on the situation. And we also sometimes have to think about, are we trying to find sperm and freeze it, or sometimes we try to find sperm and at the same time that the partner is getting their eggs retrieved, we try to time it. And that's a discussion we have with the doctors treating the female partner and myself who's treating the male. All right, so we're getting towards the end. Some key points just to keep in mind that, male factor fertility is pretty common. It's mostly treatable, and usually, especially the evaluation and most things we do are painless, so don't be scared. And let's not forget about the partner. We're not sort of treating somebody alone most of the time. And if anybody is interested in being evaluated as a male, or if the female or wants to be evaluated, or any other sort of questions, that's our number. Use this little app on your phone if you use an iPhone, and give us a call, 718-GENESIS. And that's it. That's the presentation portion, and I'll be happy to take any questions and do my best to answer them. Let's see.
Thank you, Dr. Kurgan. That was a lot of information. Before I open it up for anybody to ask any questions, I did get one question emailed in, so I want to make sure that you get to answer that one. And it's about cleaning the sperm. So if you could maybe explain a little bit more about that.
Right. So that's a great question. We call it sperm washing. It's not like cleaning, like we don't take Windex or something and try to clean it. It's actually something that, we have an excellent lab here with Dr. Goyal, our lab director. But sometimes when we're trying to increase the chances of somebody getting pregnant, we take an ejaculate, again, given in that little canister, and we're able to both spin it down to concentrate the portions that have the sperm. And there's also different ways of sort of capturing the sperm that are the most motile. And what that translates into is that we get sort of the alpha males of all the sperm to get the best swimmers, the ones most likely to be able to cause for fertilization. And most often that's done in the setting of IUI, intrauterine insemination. So we end up using a very small volume of sperm, but it's very concentrated and usually the best swimmers. And that has been proven to really increase the chances of getting pregnant compared to, let's say, having sex. Might not be as fun, but for pregnancy purposes, it can be more effective.
Okay. Well, that was the only question that was emailed in ahead of time.
Okay.
So I will open it up now. I know that we have some people here. Are there any questions that you would like to ask Dr. Kurgan?
Yeah, if you guys have any questions, please send it in the chat. And if you can't think of any questions now, we can always try to answer them either in person or you can email Donna ahead of time, and we'll try to do our best to answer them.